Good morning. My name is Larry Shulman. I'm a medical oncologist and Deputy Director for Clinical Services of the Abramson Cancer Center at the University of Pennsylvania, where we have an APN-led and staffed survivorship program. Not just staffed, but led by one. We listen to everything you say. But I'm also the Commission on Cancer Chairman. I've taken to wearing Kevlar vests when I come to meetings like this because, as I will explain to you, nobody thinks that we're doing this quite right. I wanted to make a couple of comments about how we got into this business. The Commission on Cancer is an amalgam of 57 organizations, including our main partner, the American Cancer Society, but organizations like ASCO and ASTRO and the Society of Surgical Oncology, but also patient advocate groups like Livestrong and others. And in 2012, we decided to look at our standards to see if any needed to be revised or we should add any standards. And the patient advocate groups recommended strongly that we consider some patient-centered standards, including the standard on survivorship. They were quite vocal about this, and we listened to them, and the rest is history, so to speak. We chose to develop the standard as you see on your screen, and I'm not going to read the whole thing to you, but there are a couple of points that I wanted to make. First of all, this was now 6 years after the IOM report that Maria Hewitt and others had really expert put together and has been our North Star, I think, in survivorship since then. And we felt that of the 1,500 hospitals that make up the Commission on Cancer that are accredited, very, very few had survivorship programs at all. With our standards, we like things that we can measure. And we felt like we could measure whether survivorship care plans were being given to patients, and they were also supposed to be sent to the PCPs and other care providers. So we landed on that, not because we think that the end all of the survivorship care is handing out a survivorship care plan, but we thought that it would help programs to focus on what went around the creation of a real survivorship care plan, which is really just a documentation of the work that needs to be done. And what we hoped was what Mark and Gina described this morning was that it would stimulate programs to want to get into survivorship, for hospitals to fund those programs and have outcomes that you described. That was our ideal state, and I appreciate your description of that, so thank you very much. We chose a subset of cancer patients, those with potentially curable diseases that had received treatment. And we did that not because we thought that defined the world of cancer survivors. We agree that it's much broader than that, but we felt like we needed to start with a subgroup of the patients that programs were dealing with because they couldn't do everything at once. And though initially we were going to require what Jay said was that everybody should have a survivorship care plan, that was clearly recognized initially as not being feasible for programs that had nothing to start with and were just getting going. So we created the year-by-year requirements that you see on the screen as a compromise. And we wouldn't argue with you, Jay, but we were also trying to be reality-based and try to get programs to move in the right direction. So we looked at our accreditation experience from 2016, earlier in this calendar year. There are 1,500 hospitals that are accredited by the Commission. That's about 70% of the cancer patients in the country. The accreditation is for 3 years, so every year we accredit about 500 programs, and these are the data for the 500 programs that were accredited in 2016, and we look at their data from the year before. So we were looking at their data from 2015, when the requirement was for 10% of the patients to receive a survivorship care plan. When we looked at the 500 hospitals that we accredited that year, there were about 400,000 patients who fell into the category of being eligible to receive survivorship care plan by our definition. And when we looked at the performance, there was a total of about 80,000 survivorship care plans that were delivered, and that's about 20% of the patients. So we had targeted 10%. We got 20% in that first year, and our estimate was that about 250,000 patients across our hospitals had received survivorship care plans in 2015. So not where we wanted to end up, but maybe not a bad start. So since then, we've held a number of forums at the Commission. ASCO has been very involved, and the American Cancer Society has been very involved. And we've tried to figure out whether this is the right way forward or not. I have some of my own prejudices, and I think that before we required this standard, this was not on the radar for many hospital cancer programs, and now is on the radar for 1,500 hospital cancer programs. So I think in that respect, this standard has been good in that people need to think about it, and if they want their hospital to be accredited by the Commission, they need to do something about it. Are survivorship care plans feasible in the real world? We heard, I think, various comments about this. Some people this morning and yesterday said that they're very difficult to produce, and even with electronic facilitation, they're difficult and they take a long time, and we should focus on providing the care and not the care plans. Some of us would argue, and somebody said this morning, that it's an important communication piece for the other providers, whether they're the PCPs or other medical specialists, and a good summary for the patient and the family to have as well. But they are difficult, and the electronic health record industry hasn't made them as easy as they might be, but that's a story for another day. We've been asked whether we think that the production of these are a good measure of a survivorship program. And I will tell you personally, from the anecdotal point of view, some programs are like Mark and Gina's program, which we think it got them to develop an excellent program that all of us would aspire to. And I can tell you there are other programs where they figure out how to produce a piece of paper and give it to a patient and feel like they've done their work, and there's nothing behind that. So it's clearly not the end all of getting programs to develop a good program, but it's been started. Should we maintain the requirement to deliver survivorship care plans? And that question is on the table. So I'm happy to have any input. We hope to make a final decision about this sometime in the middle of the fall. Some people have recommended that we abolish the percentages. People brought that up this morning, and certainly have brought it up elsewhere. They say you shouldn't focus on that. Focus on the components of the program. But very frankly, it's hard for a surveyor to go to a hospital for a day or two and evaluate the cancer program and really know what's going on in every aspect of their cancer program. Because remember, survivorship is just one of the areas that we review when we review cancer programs. And they could tell us a lot of things that they're doing which may or may not be correct. So we may do more of that, we may not. Some people have said the percentages are demeaning and we shouldn't do it. Others have said that it pushes programs to more seriously invest in survivorship. And then also mentioned this morning, I get a lot of feedback, if you will, from my colleagues, both medical oncologists and sometimes APNs and others, that there's no data to support an improvement in care by giving out survivorship care plans, and how can we mandate that they do this in an increasing number of patients when there's no data to support it, and it's just another unfunded, undocumented mandate. So we are reviewing all of this, but You know, as I look back on the last few years, I feel like we have raised the issue in many cancer programs, in fact, 1,500 cancer programs, but we're always anxious to figure out whether we're on the right road or we need to alter our course to accomplish what I think everybody in this room wants to accomplish. We're all believers, and that's why we're here. But as I think we've heard over the last day or two, people have different ideas about how to get there. So thank you very much.
Great, thank you.